medical advice for female pelvic health often defaults to a single instruction: do your Kegels. Whether the symptom is postpartum leaking or chronic pain, the solution offered is always the same. But this universal prescription assumes every pelvic issue stems from the same mechanical cause. The pelvic floor is a hammock-like architecture of 14 muscles in 5 overlapping layers, extending from pubic bone to tailbone. These layers support internal organs and act as a dynamic shock absorber, flexing to absorb downward pressure before automatically rebounding to their resting state. Reducing this 14-muscle support system to a single repetitive squeezing exercise fails to account for how these layers must coordinate. For many, a standard Kegel is the exact opposite of what the biomechanics require. This focus on strengthening began in the late 1940s with the work of gynecologist Dr. Arnold Kegel. He discovered that rehabilitating muscle weakness cured incontinence in postpartum patients, establishing a clinical preference for uptraining that still dominates pelvic medicine today. Kegel's research relied on the perineometer, a device designed to measure the physical pressure of a voluntary contraction. His diagnostic goal was solely to identify genital relaxation, or a lack of muscle power. Modern gynecological exams follow a different objective. They are designed to screen for cancer, infection, and gross anatomical abnormalities. They assess the health of the organs and tissues, but they are not built to evaluate the functional coordination of the muscles. This creates a consistent diagnostic blind spot. If a patient presents with chronic pelvic pain but her organs appear healthy on an ultrasound, the exam will likely return a normal result. Because the standard exam screens for pathology rather than muscle function, the clinical findings often fail to reflect the patient's lived experience. This disconnect is where the normalization of pelvic pain begins, as symptoms are dismissed simply because the organs themselves are healthy. The condition Arnold Kegel identified is hypotonicity, a weak, low-tone state where the muscles lack endurance. This often follows the mechanical trauma of childbirth or the thinning of tissues that occurs with the hormonal shifts of menopause. In a hypotonic system, weak muscles cannot maintain enough pressure to keep the urethra closed. When sudden pressure hits, the seal fails and leakage occurs. The opposite condition is hypertonicity. In this state, the pelvic floor is chronically overactive and clenched. The muscles are constantly turned on, unable to fully relax or return to a resting state. This constant tension restricts blood flow, creating a state of ischemia. The resulting lack of oxygen and metabolic buildup irritates the nerves passing through the muscle, creating hypersensitive trigger points that refer pain to the hips, back, and groin. Because these physical states produce nearly identical clinical symptoms, identifying the cause requires looking past the outward complaint. Both a weak system and a rigidly tight system can manifest as incontinence, pressure, and sexual dysfunction. This leads to a clinical paradox. A hypertonic pelvic floor is structurally tight, but it is functionally weak. This chart shows why. Because a hypertonic muscle is already contracted at rest, it has no capacity left to recruit more fibers when a sudden pressure spike occurs. Like a bicep that is already fully flexed, it cannot move further to absorb a load, resulting in the same failure as a weak muscle. Prescribing Kegels for a hypertonic patient is counterproductive. It forces an already exhausted, oxygen-starved muscle to clench even tighter, exacerbating the ischemia. If this state persists, the nervous system enters central sensitization. The brain and spinal cord begin amplifying threat signals, meaning even normal touch can be perceived as agonizing pain as the body attempts to protect the area by tightening further. Misdiagnosing a tight muscle as a weak one creates a feedback loop where the prescribed treatment for weakness actually feeds the underlying tension, driving the patient deeper into chronic pain. Since symptoms mimic each other so closely, guessing is no longer a viable diagnostic strategy. Effective treatment requires an objective biomechanical evaluation by a pelvic floor physical therapist to assess resting tone and coordination. Diagnostic tools like surface electromyography can visualize hidden electrical activity. This allows clinicians to see whether a muscle is truly underactive or if it is held in a high-tone spasm the patient cannot consciously feel. This diagram shows 2 treatment paths. For hypotonicity, the focus is uptraining, building endurance and power to restore structural support. For hypertonicity, the protocol is downtraining. Kegels are banned. focus shifts to diaphragmatic breathing, teaching the nervous system to let go and restore flexibility. Ending the cycle of ineffective treatment requires moving beyond Arnold Kegel's original strengthening bias. Recognizing that the pelvic floor is a complex mechanical system is the first step toward accurate diagnosis and care that actually resolves the underlying dysfunction.